Today we're going to be talking about antenatal care or prenatal care. They're used interchangeably. We'll be looking at ATI chapters 3 through 6 in this lecture. So this is a really important slide for you to know, and it just covers the presumptive, the probable, and the positive signs of pregnancy. If you look at the presumptive and the probable signs of pregnancy, these are really good indications that the client might be pregnant, but the only positive signs of pregnancy are the presence of fetal heart sounds by Doppler, the visualization of the fetus on an ultrasound, and fetal movement palpated by an experienced examiner. Those presumptive and probable signs could be the result of some other disease process or some other entity, like the absence of a period could be due to stress. Nausea and vomiting doesn't necessarily have to do with pregnancy. Some women, they have abdominal enlargement. Think about when we talked about the molar pregnancy. Women actually have that a fertilized ovum, however, it's not developing normally. There is no fetus present, so their abdomen will enlarge. They will have a positive pregnancy test with an elevated human chorionic gonadotropin test, HCG, and they will have nausea and vomiting. However, there's no pregnancy, there's no fetus. So just so you know, those positive signs of pregnancy are those three things on the right-hand side of the slide. The only other thing I want to point your attention to is the last bullet point on the left, which is quickening. Quickening just refers to when the pregnant mom first feels the baby move. So you may hear that in the clinic, but quickening, that fetal movement, isn't a positive sign of pregnancy. It could be just gas movement that the woman is perceiving. This slide too is very important because it's going to help you calculate the due date for your pregnant client. We use Nagel's rule, and we would want to ask that birthing person what the first day of their last menstrual period is. From there, you should subtract 3 months. So if we're going with, say, the 20th of February, we would subtract 3 months and we would get November 20th of 2022. Then we would want to add 7 days to that, and we would come up with November 27th of 2022. And finally, you add a year. So a woman whose last menstrual period was February 20th would have a due date of November 27th of 2023. The other way some providers can do a calculation is just by fundal height measurement. But this is really only semi-accurate and usually just between the weeks of 18 and 30. When measuring the fundal height, the examiners would put the end of the measuring tape on the symphysis pubis and then lay the tape up the abdomen of that pregnant woman. Then they would palpate the top of the fundus and they would read that measuring tape at however many centimeters that is. Between the weeks of 18 and 30, the fundal height roughly is equivalent to the week's gestation, but again, plus or minus 2 weeks. Pregnancy affects all organ systems, and we'll go through some of these pretty quickly. First of all, we all know that pregnancy affects the reproductive system. The uterus grows to accommodate the fetus. It goes from being about a 50-gram organ to over 1,000 grams. It's pretty big. It puts on a lot of weight. It extends early in pregnancy. The uterus is totally a pelvic organ, and throughout the pregnancy, the height of the fundus extends to the xiphoid process. There's no ovulation during pregnancy. There's no menses, no menstrual periods. Although some women do complain of having some bleeding monthly, that's the exception rather than the rule. Also, the breasts enlarge, the areolae increase in size, and they darken. The breasts can also get tender, especially in the first trimester, the first 3 months. And women also will experience leukorrhea. Leuko meaning white, and rhea is a discharge. So a whitish discharge from the vagina. It's mucus that the cervix secretes. There are also changes in the cardiovascular system. The cardiac output increases 30 to 50%, and the blood volume increases almost 50% by the end of pregnancy. Now that increase in blood volume is mostly plasma. So if you're increasing the plasma volume but not the cellular volume, you are most likely going to see a physiologic anemia in women starting around the second trimester. There's also an increase in coagulability. So pregnant women are hypercoagulable. They are more prone to have blood clots than women that are not pregnant. Heart rate increases. The heart actually does grow in size, and sometimes women develop heart murmurs during pregnancy that resolve after the pregnancy. There's also some dependent edema, meaning swelling of the lower legs, the ankles. This happens more toward the end of pregnancy in the third trimester, the third 3 months. And it's due to the pressure of the uterus on the pelvic veins. It decreases the blood return and the lymph return. So that's why there's dependent edema. Respiratory, the oxygen needs increase. Women are growing another human being that needs oxygen. The chest cavity enlarges toward the end of pregnancy, and if you think about this, the abdominal organs are kind of being pushed up by the uterus. We'll get to the GI tract. And the ribs flare outward, and the chest cavity enlarges because of the shift in all of the abdominal anatomy. The respiratory rate increases and the total lung capacity decreases, and again, that's because there's pressure from that growing uterus up on the chest cavity. Musculoskeletal, there are postural adjustments as the center of gravity changes. It shifts forward. The joints relax as a result of a hormone produced by the placenta. This hormone is called relaxin, and we talked about that when we talked about childbirth. This hormone is responsible for relaxing the joints in the pelvis to be able to accommodate the size of the fetal head. However, the hormone relaxin isn't just limited to the pelvic joints, and other joints relax as well. At the end of pregnancy, these joints will go back to normal with the exception of the feet. And women can expect to grow about a half a shoe size during a pregnancy, and that won't go back to their normal shoe size. The last bullet point on this slide is diastasis recti abdominis, and that's a split in the rectus abdominis that almost is like a hernia, but it's very common. You might see like a bulging of the abdomen as a cause of that split in the rectus abdominis, and this too should resolve after the pregnancy. In the GI system, we already talked a little bit about nausea and vomiting early in gestation. Usually this resolves at the end of the first trimester or by 14 weeks. But it can persist, and if it does persist, that would be called hyperemesis gravidarum. And we talked about that in a previous lecture. As the uterus grows, the internal organs are displaced by that increasing uterine size. Also, peristalsis slows, and that can cause constipation. Add to that, if a woman needs iron supplements that may cause constipation, this can be quite uncomfortable for a pregnant woman. So we would want to do some good teaching about how to avoid constipation. So increasing the fiber in the diet, the fluid, and trying to increase their physical activity if they're able to. The renal system changes too with an increased filtration rate due to pregnancy hormones and that increased blood volume that we talked about on a few slides ago. Also, there's urinary frequency related to that pregnant uterus and hormones. We can especially see an increased frequency in early pregnancy, and this is because in that first trimester, the uterus is a pelvic organ, and so is the bladder. So as the uterus increases in size in the pelvis, it leaves less room for the urinary bladder. So this is some anticipatory teaching that we can do in the first trimester with women. Also, toward the end of pregnancy, as the baby grows and as lightening occurs, that's that settling into the pelvic inlet, we can also teach that women can have that increased frequency based on that lightening that happens at the end of pregnancy. The endocrine system, of course, changes, and these hormones ebb and flow throughout the entire pregnancy. So that the placenta is an endocrine organ, and it does excrete hormones. HCG, human chorionic gonadotropin, is that hormone that's identified in a pregnancy test or a urine test. Progesterone, estrogen, placental lactogen, prostaglandins, these all have an interplay all throughout the pregnancy and are responsible for beginning of labor. So these hormones maintain the pregnancy and also prepare for delivery. The skin also undergoes some changes during pregnancy, and probably the most familiar are stretch marks or striae gravidarum. These happen when the skin isn't elastic enough to keep up with the growing size of the uterus. So many times women will have these stretch marks on the lower parts of their abdomen. When they appear, they're usually red, they look pretty angry, and this is a lot of times it's hereditary. Some women have really good elastic skin and they don't get any stretch marks. Other women, they could put all the cocoa butter on their bellies and they'll still get stretch marks. So very, very highly variable. After the pregnancy, it takes a little while, but these red, angry lines, they'll fade to silvery lines over the course of time, but they never truly go away. The next bullet point is called chloasma, and that's a mask of pregnancy. So it's some darker pigmentation that appears on that pregnant mom's face. The linea nigra is a dark line that appears on the middle of the abdomen, usually from the umbilicus to the pubis symphysis. Sometimes it's associated with some hair growth, very common finding in pregnancy. Palmar erythema just means their palms are red, and coupled with capillary fragility, those things are caused by increase in estrogen. With capillary fragility, you may have women complain of more frequent nosebleeds or that their gums are bleeding, and that's just due to the increase in estrogen. The psyche, there are body image changes, and where some women really enjoy the changes that are happening to their bodies and they like that that feeling of pregnancy, some don't weather those changes as well. So listen for those negative body image statements, and if need be, refer them to counseling or support groups. There are vital signs that happen, changes that happen during pregnancy. And you can see those listed on this slide. In the second trimester, the diastolic reading may have a slight decrease, but by the third trimester, the blood pressure should return to those baseline values. The heart rate is going to increase, as we discussed, and the respiratory rate also slightly increases. So our role as the nurse is to begin with preconception counseling. We really want to counsel women to be healthy before they get pregnant, if need be. If there are any problems with genetic disorders that are familial or that run in families, we would want to refer those women to genetic counseling before they get pregnant or early on in the pregnancy if they don't see the genetic counselor beforehand. So it's really important to take a good family history, schedule for genetic testing as needed. You would ask the provider to schedule that or to order that. We also want to explain all the purposes, the risks, and the benefits of all the screening and diagnostic tests that are usually done early in the pregnancy, and then answer questions and address concerns as they come up. We should be discussing costs and risks and benefits with our clients so that they can make an informed choice about the different testing and procedures during the pregnancy. We will also want to monitor for emotions and reactions after receiving or giving information. We need to be able to accurately assess and evaluate what our patients understand. During pregnancy, women may display a variety of emotions, and we need to be available to support those emotions. And then, of course, referring to appropriate support groups as needed when things arise. So listening, incorporating culture. Just because someone's culture is different than yours doesn't mean their health practices are wrong. We do need to listen to those health practices, and if they're not safe, we need to respectfully and honestly share those safety concerns with those clients. When we are with our patients, it should be a judgment-free zone so that we keep those lines of communication open and develop a good rapport with our clients so that they can be receptive to teaching. This slide just shows you the different things that would be done during that first antenatal nursing assessment. So a very extensive history, their reproductive history, including a sexual history. We want to screen for STIs. We want to calculate that due date and perform a good physical assessment, a head-to-toe assessment, including baseline vital signs, baseline weight, and the provider would be doing a pelvic exam. After that first visit at the physician's office, they usually leave the office with a lab slip, and the labs that are usually ordered during that visit are listed on the right-hand side of the slide. The woman's expected to keep going to prenatal visits. Usually they're about monthly up through about the 6th month. Then they get more frequent. And of course, if there are complications, then the woman would go into the obstetrician office even more frequently. During these visits, they get vital signs, they do a physical assessment, measure that fundal height. During the second trimester or the late first trimester, they begin taking fetal heart tones, listening to make sure the baby's heart rate is where it should be, and how fast it should be. Asking the mom if she's feeling any fetal movement yet. They dip the urine for protein to screen for problems with the kidneys like preeclampsia, and they also screen for glucose that could indicate diabetes, gestational diabetes. Then they provide ongoing education with self-care management and warning signs. So that ongoing education should be pertinent to where the woman is in pregnancy right now. For example, we wouldn't want to share information about labor and delivery and pain management techniques in the first trimester because it's not pertinent. However, during that first trimester, we would want to share information about managing morning sickness, that nausea and vomiting, problems with fatigue, sore breasts, and urinary frequency. On the right-hand side of the slide are some milestones. That top one, somewhere between 15 and 22 weeks, usually around 20 weeks, the provider will ask whether the woman wants to have a maternal serum alpha-fetoprotein, MSAFP. Now, this screens for neural tube defects, but women don't have to consent for that. They can decline having that done. Normally, around the 28th week, the provider orders those tests: a CBC to check for anemia, a glucose tolerance test, that's usually a 1-hour test, to screen for gestational diabetes. And during that visit, Rh-negative moms are given prophylactic RhoGAM. We don't know what the blood type of that fetus is, and to be safe, if there had been any type of blood mixing of the blood, we would want to make sure that the woman was covered with RhoGAM. So that's done for Rh-negative mothers. Then at the 36-week checkup, that perineal and perianal swab is done for group B strep. This is a nice graphic. It just shows you about where the top of the fundus is based on the week's gestation. So the important things on this slide are at around 20 weeks, the top of the fundus should be roughly around the height of the umbilicus. About 16 weeks, the height of the uterus is about halfway between the pubic symphysis and the umbilicus. Right around 36 weeks, the top of the uterus is about at the xiphoid process. Now, when lightening happens, we can expect a decrease in fundal height because more of the baby is down in that pelvis. When the woman experiences lightening, you can expect and you can teach the woman that she might have increased urinary frequency, but her breathing should be easier. So during these visits, we want to promote health, so promoting immunizations like the seasonal flu vaccine, as well as the Tdap, tetanus, diphtheria, and pertussis. And we do this to protect that newborn from getting pertussis. Pertussis in the newborn can be deadly. We'd also want to counsel that close family members, like the father of the baby, grandparents, and siblings, also be up to date with their pertussis vaccine. We want to counsel a healthy life cycle, so stopping smoking and substance use is important. If a woman has an infection, especially a sexually transmitted infection, we want to make sure that we teach them to take their medications to treat the infection and how to stay healthy and not get subsequent infections. Also, I want to point out the last bullet point on the left-hand side of the slide, dental care. This is really important during pregnancy because poor dental hygiene has been linked to preterm labor. So we wouldn't want that mom to get dental x-rays during the pregnancy, but we should encourage women to have their cleanings and exams during the pregnancy. We also should teach these pregnant women to avoid over-the-counter meds unless it's okay with the obstetrician. And there are medications that are safe to be given to women during pregnancy. We want them to avoid alcohol and illegal substances, and also hot tubs and saunas. Being in those hot tubs is not a good environment for that fetus because they can overheat. We do want to encourage exercise unless it's contraindicated. So in a previous lecture, we talked about preterm labor, we talked about premature rupture of membranes, abruption. Those things would be contraindicated. We also want to encourage adequate fluid intake and healthy nutrition, as well as adequate sleep and rest. This takes a toll on a woman's body, and she needs good nutrition as well as sleep and rest to be able to be healthy during the pregnancy. Also, we're going to do anticipatory guidance. So teaching them the different common discomforts of the pregnancy, providing emotional support, teaching them how their baby's growing, how big the baby's growing, what's happening. We also, early on, we want to start exploring and teaching about newborn feeding methods. Believe it or not, some women come to the hospital to have their babies and they're still not sure how they want to nourish their newborn. So starting that process early, giving them good education for the pros and cons of these methods so that they, by the end of the pregnancy, can make that good informed choice. Warning signs. This is also something that we want to make sure that we teach about during a prenatal visit. So the things on the left-hand side are during the first trimester, and we want to teach them the signs and symptoms of urinary tract infections, hyperemesis, other infections, and cramping and bleeding that may indicate a spontaneous abortion. In the second and third trimesters, we want to tell them that they should call the provider if they think their water broke, or if they're having bleeding, abdominal pain, if they don't feel their baby move as much as they're used to, and we can teach them to do daily fetal kick counts. We want to make sure that they also know the signs and symptoms of pregnancy, gestational hypertension, which include a severe headache, epigastric pain, visual disturbances, and could be vomiting. Toward the end of pregnancy, we want to encourage them to take a prepared childbirth class, and we can also do some labor teaching along with coping methods. We should be giving information about pain management strategies, and we can also refer them to a doula, or they may want to look for a doula. A doula is a certified health provider who assists with the labor. They're like an extra labor coach. And these doulas, they go to the home and support the woman during labor at home, and then they can also come to the hospital and be with the woman throughout their labor and delivery. Some doulas also follow the woman home to assist with the feeding and the newborn tasks. So talking about nutrition, a normal pregnancy weight gain is between 25 and 35 pounds total. and that's a healthy weight gain for a normal weight woman, a woman whose BMI is between 20 and 25. Their nutrition should be balanced with adequate protein and trying to minimize the fats and the simple carbohydrates. We want to make sure that they get adequate folic acid, iron, calcium, and they should be avoiding alcohol and limiting their caffeine intake. On the right-hand side of the slide, there are foods that we should counsel women who are pregnant to avoid, and that's processed or raw meat and fish. They could be associated with listeriosis, E. coli, salmonella, and toxoplasmosis. So these are serious infections for the fetus that can cause devastating results, and we want to counsel women to avoid those things. Also, raw eggs or raw sprouts, unwashed produce, unpasteurized products. Those can all cause infections that can adversely affect the fetus. Some fish can be high in mercury, so things like shark, swordfish, mackerel, some tuna, marlin, orange roughy, we would want to counsel women to avoid those fish in their diet. And of course, limiting junk food. Now, I'm like so many other people, and I enjoy my junk food, but we need to counsel women to limit their junk food. Those babies, those developing fetuses, need a good, healthy, balanced diet. This slide outlines those pregnant clients at risk. And if you think about it, adolescents, they are subject to peer pressure. Their diets aren't great. They want to drink soda and eat pizza for almost every meal. And I'm generalizing. I'm not picking on adolescents, but they're susceptible to those behaviors. Maybe it's the daily Red Bull or 3 times a day Red Bull. Energy drinks, they're not healthy for a developing fetus. We also have to worry and pay particular attention to vegetarian clients and vegan clients because they don't have that variety of protein sources. So we may have to get creative with those protein sources for them. Clients that have hyperemesis are also going to be at risk. Pregnant clients with anemia, those with eating disorders, so bulimia and anorexia nervosa. They also have body image alterations in body image, so they're particularly challenging. The next bullet point is pica, and pica refers to consuming non-food products. So you may have heard people wanting to eat like laundry detergent or soap or chewing ice or eating dirt. They're all forms of pica. And a lot of times pica is due to some kind of a deficiency in the diet. So maybe probe a little bit deeper. But definitely talking to the woman, teaching the woman that those things are not healthy to eat. Also, we want to screen for social determinants. Do clients have access to food? Do they have resources to buy food? And if not, we'd want to plug them into different social programs like WIC or food stamps, refer them to food pantries and soup kitchens so that they have adequate nutrition. We also want to be aware of those late entry into care. So generally women enter pregnancy care in their first trimester or maybe the very early part of their second trimester. We're particularly concerned about those clients that come in toward the late end of the second or early third or even late third trimester. So they have limited prenatal care, and we'd need to do a lot of teaching and also dig as to why they presented for care so late. So So some of these complications, nausea and vomiting, we've talked a lot about. Constipation, we talked about earlier in this lecture. Mothers with phenylketonuria. Phenylketonuria is a metabolism disorder, and they're unable to metabolize phenylalanine. So when that happens, there's a buildup of phenylalanine, and it can cause some devastating results. Usually phenylketonuria is identified early in newborn life, and those babies are put on an appropriate food source that limits phenylalanine. And babies can grow up to be perfectly healthy adults when they have phenylketonuria. However, we'd have to make some dietary adjustments if a mom has phenylketonuria. And then again, we have to consider diabetes. These women with diabetes, whether it's pre-gestational or gestational, will need proper diet counseling for their pregnancy. So let's talk about some calorie requirements. In pregnancy, toward the end of pregnancy, women need about 450 extra calories per day over their normal diet. So it's not really eating for two. During lactation, women require about 500 extra calories, not on top of the 450, but just over their normal, to be able to make and sustain their milk. They also need to make sure that they drink lots of fluids. So when you're taking care of a new mom who's breastfeeding, you would want to teach them that every time they sit down to feed their baby, they should get a big glass of water and sit it next to them so that they can sip on water while they're feeding their baby. Also to consider, when women are lactating, they should be eating a well-balanced diet so that they can make very nutritious milk. Moving into conception. Conception is when the egg and the sperm meet to form a zygote. So how this happens: an ovum is released from the ovary, it passes into the open fallopian tube and starts that journey downward toward the uterine cavity. At the same time, the sperm enter into the cervix and they head toward the ovum. Fertilization usually occurs in the outer third of the fallopian tube, and then that zygote, that fertilized ovum, then moves toward the uterine cavity, with implantation occurring about 6 to 10 days after fertilization. And you can see in this slide that if you haven't, every ovum is an X chromosome, but a sperm can either be an X or a Y chromosome. And if you think back into your anatomy and physiology classes, I hope you learned about meiosis, and that explains how that happens. So if an X sperm fertilizes an X egg, you're going to get a female fetus. If a Y sperm fertilizes an X ovum, you're going to get a male fetus. Multiple pregnancy happens in a couple of ways. So think about that fertilized ovum. It should turn into one fetus. But every once in a while, that fertilized ovum will completely split in half and will result in monozygotic twins. These twins have the exact same DNA. Sometimes two separate ova are released from the ovaries, and both of them are fertilized. That is a dizygotic pregnancy, dizygotic twins. And these two twins are fraternal twins. They're not identical twins like a monozygotic pregnancy. So dizygotic twins can be male and female, or they can be both male or both female. Monozygotic twins are always the same gender. So we're seeing more and more multiple pregnancies with the use of fertility technology. These are the stages of fetal development. So that fertilized ovum is called the zygotic stage, and it's from conception until the zygote divides into a solid ball of cells, and that's called the blastocyst, and that's what attaches to the uterus. Around the end of the 2nd week through the 8th week, that's the embryonic stage, and this is where the basic structures of the body organs and the main external features are formed. Finally, at the beginning of the 9th week is the fetal stage, and that stage is until birth. Pretty much, this fetal stage is just for growth and maturation. This slide just tells you that there are 3 embryonic layers, and I'm not going to test on this information, but you may see it on the NCLEX. I'm not sure about that. It just shows which layer forms which tissues in the embryo. And then this is just a slide about the placenta, and that picture on the right hand side kind of reminds me of a tree, or like the tree of life. Placentas are usually about circular in shape, and that right hand slide, that is the fetal surface. It's smooth. You can see that the umbilical cord comes into almost the center, and then it branches out to the different vessels that supply the underside of the placenta. The underside of the placenta, there's a cutaway like graphic on the left hand side. That cutaway is what adheres to the inside of the uterus, and that's where all that nutrient and gas exchange happens. On this slide, you can see the picture of an umbilical cord, and it's the lifeline from the mom to the growing embryo and fetus. It contains 1 large vein and 2 small arteries, and you learned about that in one of the first lectures this semester. There's cushion that surrounds the vein and the arteries, and that's called Wharton's jelly, and that helps to prevent compression of those vessels. And at term, the average umbilical cord is about 22 inches long and about 1 inch wide. Now for preterm babies and babies that are SGA, the umbilical cord might look pretty scrawny and not have a lot of Wharton's jelly. If you look at the umbilical cord of an LGA baby, that one's going to be nice and fat and plump. This slide tells you the role of the amniotic fluid, and it helps maintain a constant body temperature for the fetus. It permits symmetric growth and development. The baby bounces around inside that amniotic fluid. It cushions the fetus from trauma, and it also allows the umbilical cord to be relatively free of compression. It also promotes fetal movement to enhance musculoskeletal development. This should be a familiar slide because we talked about it when we talked about the newborn. So around the 3rd week of conception, about the 3rd week, the heart begins to beat, and it eventually forms a 4-chambered heart in the 4th to 5th week. And this slide also shows those 3 shunts that bypass the lungs and the liver, so oxygenated blood gets to the rest of the body faster. Now we'll talk a little bit about assessments of fetal well-being, starting with an ultrasound. It's probably a very, very familiar term, and it uses sound waves to show outlines of the fetus and fetal structure. You can see in the center of this slide why it's done. and it may be due to some vaginal bleeding, discrepancies in the fundal height with the dates, could be for decreased fetal movement. It may be done to confirm the pregnancy. The next thing I want to talk about is a fetal non-stress test, or NST. You might hear NST on the clinical unit. And this test is very widely used. It's non-invasive, it's pretty easy to do, and it doesn't take very long. This test assesses the fetal central nervous system well-being. What it requires is the woman to be connected to an external fetal monitor, and as the woman is being monitored, we're looking for 2 accelerations that are at least 15 beats per minute above the baseline, sustained for at least 15 seconds. Having 2 of those accelerations within a 20-minute period means that it's a reactive non-stress test. If it's non-reactive, then the provider will probably order a different test, and we'll get to those in a minute. So on the right-hand side, maybe the pregnant woman said that her baby wasn't moving as much as she was used to. Maybe there's a diagnosis of intrauterine growth restriction or baby post-maturity. Any number of reasons women can have this non-stress test to check for fetal well-being. The next one I want to talk about is a biophysical profile, or BPP. And I want you to know what is measured with a biophysical profile. A biophysical profile is an ultrasound exam that looks at the fetal heart rate. It looks for fetal breathing movements. Yeah, the fetus chest expands and contracts as if it were breathing, even though it's not breathing air. It also looks for gross body movements and fetal muscle tone. And it also measures the amount of amniotic fluid pockets. So each of those 5 criteria are scored as 0 or a 2, for a total score of anywhere from 0 to 10. The higher the score, the better the well-being of that fetus. So scores of 8 and 10 are very reassuring, and 6 and less are not as reassuring. This may be due to a non-reactive non-stress test that I mentioned on the previous slide, or any of the other reasons noted on this slide. The important thing that I want you to note on this slide is what is measured during a biophysical profile, and understand that the numbers that are assigned are either 0 or 2. So there can never be an odd number assigned as a result of this test. The next one I want to talk about is the contraction stress test, or CST. Now, truly, I haven't seen this one done much at all in my 25 to 30-year career in OB. However, every once in a blue moon, the provider orders this. So what the provider is looking for is how the fetus reacts to contractions. So remember when we learned about late decelerations and variable decelerations as a result of some contractions. The provider is really looking for how the baby is going to handle labor. So we need to produce some contractions, and this could be done with oxytocin, as if the woman were being induced, or we can also do some nipple stimulation, whether it's digital stimulation or using warm compresses to the nipple. We'd first want to assess the fetal heart rate. First, we would want to make sure it was a non-reactive, non-stress test. And then we would start to stimulate contractions. The test is negative if there are no late decelerations. That means the fetus is doing okay. And the contraction stress test is positive if there are late decelerations with at least 50% or more of contractions. So again, we're assessing the fetal tolerance of contractions that will help us predict whether the fetus is going to tolerate labor. The next test that I want to talk about is an amniocentesis, and this could be for an alpha fetoprotein, which again is associated with neural tube defects. It could be done for a chromosome analysis, so they may withdraw fluid and then they might do a fetal karyotype, looking for different anomalies, genetic anomalies. They may also do an amniocentesis to check for lung maturity, and this is where they would measure an LS ratio. And finally, they may do the amniocentesis to do percutaneous umbilical cord sampling. This isn't very common. This isn't very common either, chorionic villus sampling. This is usually done in the first trimester as an alternative to an amniocentesis. In essence, the fetal karyotype can be done sooner than waiting for an amniocentesis. However, there are many complications, and again, I don't hear of this being done very often. So there's a risk for spontaneous abortion or miscarriage, risk for fetal limb loss, chorioamnionitis, which is an infection of the amniotic membranes, also a risk for rupture of membranes, and during the first trimester this would not be a good thing. And finally, we want to talk about the quad screen, which is the list on the left-hand side of this slide. So an HCG, human chorionic gonadotropin, an alpha fetoprotein, estriol, and inhibin A. And this is done to screen for anomalies and to provide some anticipatory guidance. Specifically, if there's a low AFP, then there may be an increased risk that this baby may have Down syndrome. If there's a high AFP, that infant is at a higher risk for neural tube defects. I hope that you've enjoyed this antenatal care PowerPoint presentation. Please let me know if you have any questions about these slides.